So the next three speakers are going to be a panel style discussion. So we'll let all three of them present, and then we'll have questions and discussion after. Our presenters will be Lydia Vincent. She is BSN here at Eisenhower. She is the chest pain coordinator. She started her nursing career in 1999 as an ICU nurse in Meridian, Mississippi. She joined Eisenhower Health in 2010 in the ICU. She has then worked in various areas of the organization, including ICU, surgical services, emergency department, and cardiovascular services. Lydia is most passionate about reaching the community and educating on heart-healthy habits, early heart attack care, hands-only CPR, and automated external defibrillator use. Our next one is Clara DeSha. She is an acute care practitioner here at Eisenhower Health in cardiothoracic surgery. She began her nursing career in 1997 here at Eisenhower. She continued her career working in cardiac surgery and pediatrics at Loma Linda Children's Hospital in 2000. She returned to Eisenhower in 2004 to critical care, specializing in open heart surgery recovery. She obtained her graduate degree as an acute care nurse practitioner in 2019 and transitioned to a full-time role as a nurse practitioner with cardiothoracic surgery here at Eisenhower. Julia Wood is one of our 3 valve clinic coordinators for the structural heart program here at Eisenhower. She started her nursing career in 2018 when she received her second bachelor's degree and worked at UCSD in the trauma unit. She began working at Eisenhower in 2021 and has had various nursing positions, leading to her current role as the valve clinic coordinator for the past 2.5 years. Julia has enjoyed working in a leadership position for the Cardiovascular Institute and continues to help grow the structural heart program with a multidisciplinary team.
Hello, everybody. Everyone's still awake? Got to the end of the day. I brought this is a pretty quick lecture. And I took some time trying to think about what to talk about with the 15-minute allotment. And because I deal with this all the time, and because there was a rather timely article that came out, a consensus statement from the Society of Thoracic Surgeons regarding heart failure, and how we initiate therapy after heart failure and what our role is in that as a cardiothoracic surgery practitioner, because I take care of these people, and I know there's probably some of my patients in here. I know there's a big mended hearts group here, so you guys have all had heart surgery. There's a pretty good percentage of our patients have heart failure. And so I'm treating them. So Dr. Patel did a great job this morning talking about heart failure and the guidelines for heart failure and how we diagnose heart failure. And I'm going to really quickly breeze through some of that and then talk about what our role is and what the role is of other practitioners in the hospital, because this really can apply to other like hospitalist practitioners. I know there's a few of you here and I have no idea who's on Zoom right now. You guys are probably a bunch of you out there. So really quickly, some of the challenges of implementation, some strategies that I use to implement goal-directed medical therapy for heart failure, and also the importance of a multidisciplinary approach to this, because you know, I'm a heart surgery provider. I want to manage my heart surgery patients for about this much time and then get them over to their cardiologist to take over. Again, I think one of the important takeaways is that every hospitalization can be seen as an opportunity for patients with heart failure to actually initiate goal-directed or guideline-directed medical therapy. And guideline-directed medical therapy, and I'm mainly going to talk about in heart failure with reduced ejection fraction, but there's guidelines for heart failure with preserved ejection fraction. So a couple things that we use so heart failure is measured both objectively and subjectively, and this is what Dr. Patel went over with you guys today. So objective measurements are things like your echocardiogram measuring ejection fraction. We, in the heart surgery population, have the advantage of having some hemodynamic monitoring. We can look at filling pressures, and of course, increased natriuretic peptide is something that he talked about. That's an enzyme produced by the heart muscle that we know when that increases, and we can sort of trend this number, that that can signify that there's some objective heart failure, also subjective symptoms. So how does the patient feel? And this is, there's a New York Heart Association classification that we still use in heart surgery to kind of have an idea of where patients are at. And then Dr. Patel spoke with you guys about the American Heart Association and American College of Cardiology, the A through D classification. And so when I think of heart failure that I'm going to treat in the hospital, I'm thinking New York Heart Association class 3, and probably you're looking at the D classification for ACC classification. So heart failure still, and I know he talked about this, remains the leading cause of hospitalization and of course rehospitalization and readmission. And it's a leading cause of mortality in this country and in other countries, but in the US specifically. In our population, as many as 25% of our patients are affected by heart failure of one form or another, either with preserved or with reduced ejection fraction. And we have about, I want to say about, I think the data that I found was that 16% of our patients, when they're readmitted, the readmission includes a heart failure diagnosis. So even if they're not admitted with heart failure, they have a heart failure diagnosis on top of their admission. Just a really quick review of these are the guideline directed medical therapies. And this is what I'm focusing on today. There are lots of other therapies to treat heart failure. We use loop diuretics in almost all of our heart surgery patients, and that's not included on this slide. But the big four pillars that are on the guidelines, first of all, beta blockers. And beta blockers are something that there's a lot of crossover with open heart surgery patients because we use them anyways. It's part of our guideline recommendations as well. There's 3 specific beta blockers used for heart failure. That's metoprolol succinate, and there's 2 metoprolols. Remember, there's metoprolol tartrate, that's a short acting that we typically like to start with because it's short acting. We know it's going to go away, but metoprolol succinate is the heart failure specific beta blocker, and then carvedilol and bisoprolol. And then the renin-angiotensin inhibitors, those are equally, it doesn't matter which one you use, it's a big spectrum. There's your ARB agents, your ACEs, and then of course your ARNIs, which is your Entresto. And then I have the hardest time with this word, mineralocorticoid receptor antagonist. This is spironolactone, and there's another one called eplerenone that you'll sometimes see, but typically spironolactone. And then the golden heart failure medication right now, and this is because we've found that there is so much benefit to starting SGLT2 inhibitors on these. This is a medication that was initiated for diabetes that we use in lower doses for heart failure, because during the clinical trials for diabetes, they found that there was a huge improvement in heart failure treatment with these drugs. We know that if we can get people on all 4 of these medications, it does a few really important things. Number one, it reduces mortality. It reduces morbidity as well. So that's the side effects and the rehospitalizations. The benefits of treatment can be seen in as early as 1 month, and almost most importantly is it improves quality of life, right? So if we can get people on these medications, they can actually go from having the ability to only walk to the bathroom to being able to live a pretty normal life. Despite what we know about getting all 4 of these treatments started, there's a little bit of, I don't want to say pushback, but it's hard to get people started on 4 medications because you have to have a lot of touch points with medicine. So that's why hospitalization provides a really great opportunity for us to get started on them. So one of the things that we do, so despite evidence, we know that real world usage remains kind of suboptimal. There's not an abundance of literature in the heart surgery population, but again, we just had a consensus statement come out that says, we really know that this population is pretty well studied and also very well monitored. And heart surgery providers have some advantages. Number one is that our patients are really well worked up. We know a lot about them. They've had echocardiograms, they've had angiograms. They're well monitored after surgery because it's a pretty vulnerable population of patients. So we know that they're a little unstable, so they have hemodynamic monitoring. They have EKG, continuous EKG monitoring, and they have frequent labs. And so one of the things that when you start these medications, you have to watch people's kidney function, you have to watch for arrhythmia. We also have the ability to really quite quickly in the inpatient setting, perform another echocardiogram or get chest x-rays, which we all know in the outpatient setting can take weeks, sometimes months to get done. And lastly, we have nursing staff in the hospital that helps to monitor people. So they can monitor for subjective symptoms, and nurses pick things up all the time. So you have expert people watching them. Another opportunity for us, another advantage that we have as cardiac surgery providers is people get a lot of touch points with medicine. So they're seeing us in the hospital, but they're also seeing us in the outpatient setting. So there is evidence now, when guideline-directed medical therapy for heart failure was first became popularized, and we've started using it a lot more frequently, and I see people on these drugs more often now. It used to be that we would start one medication and titrate it up to the optimal dose and then start another medication. But now we know that actually, ideally, what we should be doing is trying to get all 4 medications on board, or as many of them as we can, as are tolerated, and then titrate them to optimal dosing. So sequentially maximizing a single drug, sometimes they just don't tolerate that. And I think somebody had asked earlier about why would you try to take one drug all the way up to the top dose? Well, you can't always get somebody to the top dose. So ideally, what we try to do is get all 4 drugs in place, because there is some evidence that there's a synergistic effect when you do this. So typically what we'll do is we'll start with a beta blocker, because like I said, we have some guidelines and metrics that we follow for open heart surgery, and beta blockers are usually one of our first line agents that we start. And also following that, I will typically either start on Jardiance, because Jardiance is pretty well tolerated. Jardiance is the SGLT2 inhibitor, and it's a single dose. You don't have to titrate it. It's usually pretty well tolerated. There are some exceptions with diabetic patients. You have to be careful if they're on insulin, because they can be hypoglycemic. But again, there's also some crossover with the RAS agents. So if you're having problems with high blood pressure, then that's the medication that I'm going to go with. There's no right or wrong answer to how you start these medications. The goal is just to get them on board and not wait 6 months between adding them, because that's the thing that happens when people are outside of the hospital, is they don't see their physician for 6 months and things don't get added. So things that I consider postoperatively that are very specific to us is these people just had open heart surgery, so they can have some vasoplegia or some lower blood pressures. They're sometimes a little bit hemodynamically stable because they've been on cardiopulmonary bypass. They're much more prone to heart arrhythmias. There was a lot of talk about atrial fibrillation. Atrial fibrillation is a huge problem after open heart surgery, so that can be a limiting factor, as well as slow heart rates, which is your bradycardias. Blood pressure, blood pressure, blood pressure. You know, a lot of times we're limited on what we can add because of blood pressure, and then also kidney function, because most of the agents, except with the exception of the beta blocker, will have some effect on kidney function, and we have to monitor. And of course, diabetes is consideration if you're going to try to add Jardiance. I know there's probably a lot of you that have expensive medications. So things like Eliquis are very expensive, and so the ARNIs are expensive, as well as the SGLT2s are pretty expensive. So what do I do differently if I know somebody is possibly a candidate for guideline medical therapy for heart failure? One of the first things I do is I identify who they are, right? I go back, I look at their symptoms, I look back at their imaging. Do they have a reduced ejection fraction? Am I possibly looking at heart failure with a preserved ejection fraction? Do they qualify for me to be starting some of these treatments on them while they're in the hospital? Second of all, I kind of make a goal for myself while they're there, that I'm going to try to get them on these medications before they go home, while they're monitored, and then I'm going to follow up with them once they get home, because it may be 3 weeks or 6 weeks before they're able to see somebody else. I often will get somebody, if they have their own cardiologist, I'll get a hold of them. I try to get expert consultation on board, just to kind of see, you know, we try to talk to one another in our service. We work very closely with the cardiologists, and we really try to make sure that they're, these are patients that they know better than me. So we want to make sure that they're on board with doing the same therapies that we're talking about. And then because we use metoprolol tartrate very often, one of the things I have to do is make sure that we've actually started using a heart failure specific beta blocker. That's the one medication that should be very specifically, there's only 3 of them on the list that we want to use. Patient education. I can't stress this enough. I can only do, and providers can only do so much if we send people home and they have no idea what their medications are for and they have no idea to watch their salt intake, then all of my therapies aren't going to work, or if they weren't able to pick it up because it was too expensive. So I spend a lot of time as I start things in the hospital, when I send people home, when I see them in the clinic, I talk to them about their medications. This is what I started today. This is why I started. This is what we need to watch for. I try to get family and caregivers involved in this because, it takes a village. And in my population of patients in open heart surgery, and I don't know how many people here have had open heart surgery. Yeah, the big group in the middle. Everybody has a little brain fog, right? Everybody's feeling a little fuzzy. So I usually try to get family members involved, and, the wife or the daughter is taking notes. I go really heavily over any changes that I made to medications and why I made them, and dietary restrictions. Dr. Patel said that if somebody eats a big salty meal, their BNP level is going to go up, their natriuretic peptide is going to go up. Well, if you eat a big salty meal and you have heart failure, it's going to overload your ventricle. And really, a lot of people are just one big Chinese meal away from landing in the hospital. And some of our patients are that fragile. And I tell them things to look for. So daily weights are super important, and people often don't realize the importance of daily weights in heart failure, but daily weight is an early indicator that somebody's holding on to water, because people can sequester water in their belly. It's not always pedal edema. It can be other smaller symptoms, and then watching for symptom monitoring like shortness of breath. And then this is super important, post-discharge follow-up. So we have a lovely heart failure clinic, and we have really great results if we get people to our heart failure clinic. The last I heard was 0% readmissions this year for anybody that's been sent to the heart failure clinic. That's huge. That's huge. That beats any benchmark across the nation. I usually set up outpatient monitoring. If I'm sending somebody home on new medications that I'm worried are going to affect their kidneys, I'll order some serum labs, because I know that I'm going to see them in a couple weeks, and I can easily follow their labs at least while I'm seeing them and make sure that they're stable, and maybe be able to add something or titrate something when I see them again. Chest x-rays, we get chest x-rays on everybody. And then I create touch points. And what that means is that we don't just send people home. We give them a call a friend. They get to call us if they have any symptoms. We get them to the heart failure clinic. We get them back to their primary care provider so that they can see the changes that we made. And a lot of times, most of the time, I'll order home health so that they have another set of eyeballs looking at them when they get home, and referral again to the heart failure clinic. And lastly, most importantly, I try to get them back to cardiology, because these guys are the experts, right? I'm just babysitting them for a little while, and it's really important that they have ongoing monitoring, and that they're able to have another echocardiogram down the road, and an expert that can titrate up their medications to where exactly they need to be. If there's no cardiologist, I work really hard to get people referred to a cardiologist. It's 30% of my job in the clinic sometimes. So some key takeaways. Heart failure is the leading cause of morbidity and mortality, and can affect up to 25% of our patients. That's just heart surgery patients. Early initiation of the 4 pivotal class of drugs that we talked about can have positive results in as little as 30 days. So it's very impactful, and it can be impactful quickly. Hospitalization in general, but especially for us, provides a controlled environment that is really an opportunity to get things started and initiate, or even fine tune, because sometimes people are on medications and we can fine tune them when they're there. And then close follow-up, making sure that people are able to get with their cardiologist. That's really instrumental to their long-term their long-term success. How is it? Any questions? Sorry, I stumbled a little at the beginning there.
Thanks, Christine. Thank you everyone for still being here. I know it's been a long day, but hopefully very informative. My name is Julia Wood. I'm one of the 3 valve clinic coordinators here at Eisenhower for the structural heart program. Today, I'm going to be speaking to you about TAVR and kind of the nursing perspective of that. So, disclosure, I am a consultant for Edwards Life Sciences. First, my outline just for today, first, we're going to review quickly the ideal TAVR patient candidates and their eligibility criteria. Next, we'll look at the key nursing findings during the TAVR workup process. Then we'll discuss the pre and post TAVR nurse intervention care. And lastly, we'll review the nursing impact on patient treatment and their lives. So our ideal TAVR patient is someone who is severely symptomatic with severe aortic stenosis with a high risk for surgery or is not a surgical candidate. So briefly, some of these symptoms include a heart murmur, chest pain, shortness of breath, dizziness or lightheadedness, fainting, syncope, difficulty walking short distances. Patients that are typically not surgical candidates have what we call a high Society of Thoracic Surgeons risk score or STS score. This score determines their mortality risk for a surgical approach to replace the aortic valve. If a patient's STS score is greater, typically than about 3%, this is considered an intermediate to high risk surgical patient, and therefore the patient's better suited for TAVR. So patient selection for TAVR is supported by a multifaceted evaluation process, as shown here. Our TAVR team here at Eisenhower, we meet on a weekly basis. It's a multidisciplinary conference, and we focus on first, sometimes the patient's age, typically, but not always, our patients are above 80 years old. The STS score is high, as we just discussed. Then we look at some of their functional and cognitive abilities. So are they making medical decisions on their own? Do they have any dementia? What's their social support at home? Do they live independently? And then what other comorbidities do they have that may affect their procedure or recovery? And what's their anatomy? Is there anything that's limiting us for like during the procedure or during the recovery process? Of course, our heart team is also adheres to the ACC and AHA valvular heart disease guidelines that identify aortic stenosis to be occurring in a series of stages, A to D, D being the most severe. And this grades the patient on severity of stenosis, onset of symptoms, degree of their LV dysfunction. Something I find interesting that Dr. Frucken mentioned earlier this morning is the current guidelines recommend routine clinical surveillance, so echoes, every 6 to 12 months for patients who are asymptomatic with severe AS and a preserved LV function over 50%. However, as you can see over time, our thresholds for intervention for TAVR have slowly been lowering, and there's more and more durable treatment options. So there's that early TAVR clinical trial, which is showing that early TAVR intervention in asymptomatic patients with severe AS is superior to the clinical surveillance in reducing stroke, death, or unplanned cardiovascular hospitalizations. So it's going to be interesting in the next, hopefully, year or so. We're going to see these guidelines change and open up TAVR to more patients. Just going briefly into the key nursing findings during the workup process. Typically, our first identification of aortic stenosis is through an echo. So patients can have the typical high, severely high gradient aortic stenosis, where their velocities are over 4 meters per second and their mean gradients over 40. Or patients can present with what we call severe low flow, low gradient severe AS, where their velocities and mean gradient are actually lower, because their ejection fraction is usually less than 40%. These patients are sometimes missed, and so we also do more testing on these patients to confirm that severe aortic stenosis. To verify, we verify their findings with an angiogram or a right and left heart catheterization. This will also show us if there's any coronary artery disease, if the patient needs a stent prior to TAVR. We then schedule a CTA heart with calcium score and a CTA chest, abdomen, pelvis, which are done simultaneously. A common question that I get as the nurse that I'm scheduling these CTs is why do I need a CT? I just got this right and left heart catheterization. I've had an echo. Well, the CT specifically shows us what size heart valve the patient is going to receive and identifies how we're going to access the patient appropriately for the procedure. Some other nursing considerations are subspecialty referrals. For example, do patients have any current dental procedures going on? Do they need to be cleared by infectious disease? Something that we see pretty commonly is we get these CT scans done and there's a pulmonary nodule that the patient didn't know about. And so then we have to go through the workup process of sending them to the pulmonologist. And so that's something that I do on a daily basis, is kind of monitoring those patients, making sure those referrals get through. We're also looking at family support. Does the family need extra education? Is there any expectations that we need to set for the family? This goes along with anticipating any post-procedure or early discharge needs, which can include transportation, need for home health, medication instructions, post-procedure wound care. So pre-TAVR nurse intervention care, some things to be considered. The patient needs to be NPO or nothing by mouth after midnight the night before. We typically start 2 peripheral IVs and an arterial line by the anesthesiologist in pre-op. Echo imaging is available for reference, making sure that's there. Medication-wise, patients should be off their anticoagulation for about 3 to 5 days. Typically, we give Plavix and baby aspirin in pre-op and a dose of IV prophylactic antibiotics as well. We also want to make sure consent signed, of course, for patients that we're accessing them via their carotid artery. We mark the laterality, or the surgeon marks that. We do not place urinary catheters. Our procedures are less than 2 hours, and ensuring we have 4 units of PRBCs available and ready to go. And lastly, making sure we have all those pre-op nursing orders and orders in general. Okay, so post-TAVR nurse intervention care items. Of course, we are looking at their vital signs, doing thorough neuro checks, checking for any signs, symptoms of stroke. We also want to be checking peripheral vascular checks. I can't stress this enough. Checking distal pulses for the color and temperature, assessing for any arterial occlusion. Damage to any of these arteries could require an urgent surgical intervention or repair. Of course, we're assessing for bleeding at the access sites typically. So their femoral arteries or their carotid incision. Any slight oozing is normal, but a hematoma or active bleeding, of course, is not. And then retroperitoneal bleeds can also occur. So symptoms of that would be back flank pain, sudden decrease in blood pressure, increase in heart rate. Arrhythmias are also very common post-procedure or even during the procedure. Typically what we see is a new bundle branch block or even sometimes a complete heart block, and this would require a pacemaker. Hypertension, we do allow for permissive hypertension, however, it needs to be monitored closely. And the patient is to remain flat for about 4 to 6 hours. I probably should say 4 to 6 instead of 6 to 8 to prevent bleeding. But early ambulation is also strongly encouraged after that to promote a faster recovery and reduce the risk of complications. And then, of course, we're trying to discharge them within a 24-hour period. So providing that education that's focusing on post-procedure medications, use of any prophylactic antibiotics prior to dental work, and wound care, which is very minimal to none, and no heavy lifting for about a week. Nurses truly have a great impact on the patient's lives and timely treatment. One way there's been a positive impact that's been demonstrated here at Eisenhower is through what we call the KCCQ questionnaire, which determines the patient's acceptable quality of life we do this at about 30 days and 1 year. As you can see, the national average here is 72% according to the national database. And Eisenhower here, looking at Q4 2023 going to about Q3 2024, our average was about 80%. We're over that national average. So that's been a great way to track our patient satisfaction. We also facilitate rapid reconditioning as nurses post-procedure, which I've mentioned previously, focusing on nurse-led interventions to return to their baseline. So the patient family education, early ambulation, achieving the goal of next day discharge, and then ensuring that there's a cardiac rehab referral. I also wanted to highlight the reduction of Eisenhower's 30-day readmission rates for our TAVR patients, and specifically demonstrated by a TAVR team project at Eisenhower that was conducted by a multidisciplinary team. This project focused on the education and transition to bring to appropriate TAVR patients recovering in the ICU to recovering to our 4th floor cardiac telemetry unit. This was a project that was done in the end of 2020, early 2021 time. As you can see on this graph, the pre-intervention 30-day readmission rate was about 23% in Q2 2020, which then decreased to about 10% in Q4 2021 with this intervention. And so the intervention, it focused on recovery outside the ICU. So again, transitioning from the ICU to the cardiac telemetry unit. We also focused on conscious sedation during the TAVR procedure and a goal of next day discharge. So we really focused on staff education, all while promoting safety and improving outcomes during that transition. So this is just a part of our structural heart team here at Eisenhower. A few of us have already spoken today, and we really couldn't maintain excellent quality and outcomes for our patients without other people not pictured here. So all the supporting staff from the cath lab, OR, echo team, Borsal, special procedures unit, the desert cardiology team. If I missed anyone, thank you. Anybody who's listening on Zoom. Just wanted to take a moment to thank everyone who's involved in the structural heart program. At the bottom is our office number here. If you have any questions, feel free to call us anytime. Thank you.
Hi, everyone. I see some familiar faces out there. I'm Lydia Vincent. I'm the Chest Pain Center Coordinator here at Eisenhower. Eisenhower is a chest pain center accredited through the American College of Cardiology. And so I'm going to talk a little bit about accreditation today. Oh, my title screen went away, so it threw me off. I do not have anything to disclose. I want to discuss a little bit about accreditation. We have many accreditations here through the American College of Cardiology. A lot of you are familiar. All of you are familiar with the U.S. News and World Report 2025 Best Hospitals, which Eisenhower is usually in there. But also I wanted to make you aware that the ACC usually has an insert. The American College of Cardiology has an insert also in that magazine, talking about all of their hospitals who participate in all of the different accreditations that they provide. You can see here, there are 8 different registries that you can be a part of that are through the ACC. There are 6 different accreditations, and there are 4 different awards that you could be awarded by the ACC. They rank these in this insert by state, and they rank them based on how many of these things that you participate in as an organization. And you'll see here for the state of California, it's hard to see because that thing's in the way, but Eisenhower is on the top of the list because we participate in the most out of the state of California in all of those accreditations, registries, and awards. Also to be noted, these are the awards. So it says 2024 because this is the hospitals that participated in 2024 in these particular accreditations. So in 2024, there were only 4 hospitals in the Western United States who have been accredited, heart failure accredited with outpatient services, and Eisenhower is one of those 4 hospitals. And then also, the ACC only has 4 hospitals in the entire United States who have been awarded all of the ACC accreditations, and Eisenhower is one of those 4 hospitals. So, absolutely. I think that is important to note. What that means for you as an organization and as a community is that Eisenhower is sorry, I got nervous. I saw my wife over here. Eisenhower is invested in making sure that you are all getting excellent care, that we are giving guideline-driven care. I think you've heard everyone up here who has come up here talk about guideline-driven care. And when we participate in these accreditations, we have to prove that to the American College of Cardiology that we are actually giving guideline-driven care to our patients. We participate in these registries, which mean that we put the patients in registries to show exactly what they came in with, what were their symptoms, and what were their outcomes, what were their treatment while they were here. We don't give a specific treatment that is recommended, we have to say why we didn't. Was there a clinical reason why we didn't give that treatment to that patient? So this is very important for our organization to make sure that we are staying on top of the guidelines, but it's also very important for you as patients to know that you are getting guideline-driven care and that we're monitoring it to make sure that we're staying where we need to be as an organization. So this past year, we decided to participate in the chest pain MI registry. As I said, I'm the chest pain center coordinator, so I look at a lot of those patients who come in with chest pain, whether they get discharged from the hospital, whether they stay in the hospital. If they're having a heart attack, I look at all of those patients. And we put those patients into our registry. And they have an award program, a performance achievement award program for hospitals that participate in this registry. And we're hoping to receive our first award, hopefully this year. To receive an award, you have to meet specific metrics in defect-free care, which means that you hit every care opportunity that was there for that patient and you did everything correct 100% of the time. There's also metrics on STEMI care or ST elevated MI care and non-STEMI care. And so we will only be eligible this year for a silver award because this is our first year. To become gold or platinum, you have to have participated and shown that you can keep those levels up. You can sustain them. So this first year will only be eligible for a silver award. So we'll have to show that we can give defect-free care 65% of the time, meet our STEMI metrics 80% of the time, and our non-STEMI metrics 80% of the time. That's what we will have to meet. So this is where we are for 2024. I don't think we're going to have any problem meeting these metrics. Our defect-free care overall was 70%. STEMI performance composite 97.3. and non-STEMI 92.9. So as you can see, we have exceeded that silver benchmark, but that will be the only level that we are eligible since this is our first year participating. And if you want to know a little bit more about what are those performance measures that fall into those metrics that they're looking at, these are the metrics. They want to know that if a patient comes in after a cardiac arrest and is deemed to be due to an ST elevated MI, that they are going straight to the cath lab. If for some reason our cath labs are blocked by patients, and we have a STEMI that comes in and we can't get them to the cath lab, that does not happen very often. I've been doing this for 4 years, and I think once during COVID, when it was, kind of crazy out there in the world, was the only time. But they want to see that we can give fibrinolytics within 30 minutes from the time that patient comes in the door if they're identified as a STEMI, but that's not something that we have to do very often. They look at door in to door out times, but that's not us. We don't usually send any STEMI patients out. We take care of them in-house. Our first medical contact to device time, less than or equal to 90 minutes for all of our STEMI patients. That's the goal that you have to have. Our goal here at Eisenhower is 60 minutes, and we hit that metric most every month. So I think our fastest STEMI here, door to balloon, is 23 minutes. But that can only happen with early activation, with patients who are having symptoms, calling 911 and making sure that they're getting appropriate support. Our EMS system is great here in the Valley. And when you call 911, you need to think of that as an extension of the emergency room. They're going to get to you. They're going to assess what's going on. They're going to get that ECG. And if it shows that it's a STEMI, they're going to call us, and our cath lab is going to be on the way and probably ready before you even get to us. So, that we're doing appropriate reperfusion therapy for our STEMI patients. They get aspirin on arrival, that we do early troponin measurements for our non-STEMI patients. So our goal for our troponins is arrival to result in 60 minutes. So if that ECG is not really telling us what we need to know, it's not showing that you're having a STEMI, we're not sure what's going on. We want to make sure we can get that troponin level to see if you're having a heart attack, and we need that result within 60 minutes. So excuse me, early troponin measurement is one of the measures. They want to know that if you've had a heart attack, that we're looking at how your left ventricle is functioning before you leave. So did we get an echo, or did we look at that while you were in the cath lab? And then there's medications that we need to know that you're discharged on, which is the P2Y12, aspirin, beta blocker. If you do have a reduced ejection fraction, did they order an ACE or an ARB? And then did they discharge you on a high intensity statin? And then also one thing that's really, really important is cardiac rehab. I'm not sure if anyone's talked about our wonderful cardiac rehab program. I know that we talked about our heart failure clinic, but we have a wonderful cardiac rehab program here at Eisenhower. And if someone comes in with a heart attack, they deserve to go to that program, because it can really impact the rest of their life. So those are the things that they look at for the defect-free care and the STEMI and non-STEMI composites. If there's any physicians out there, I've sent messages to physicians. The only patients that fall into these metrics are patients who are having a type 1 MI. So that's STEMIs and non-STEMIs. So someone who has some type of occlusion going on that might need an intervention or might need medical therapy. But there's also type 2 MIs, and then there's troponin elevations due to other causes. So sometimes I'll send messages to physicians just to make sure we're getting that discharging diagnosis clear, so there is no confusion for that discharging nurse or for that person who might be coding that chart afterwards. So sometimes I send little messages just to make sure we get that correct, so that we have the true population of patients in our registry. And then there are some reasons when there are troponin elevations that are not really considered type 1 MIs, they're type 2 or troponin elevations due to other causes. And so this chart can be found on our physician learning homepage. And these are just some of the other causes that are commonly seen for type 2 MIs and troponin elevations due to other causes. So I just share this because I know we have some providers who might be listening, just so they're aware that this chart is available on our physician learning homepage. So as you can see, our numbers, I don't think we're going to have any problem gaining that silver award However, we do have a PI project going on to make sure that we don't miss anything. As you can see, there was quite a few medications that were on those metrics that they have to order for these heart attack patients. And so there are some things that we've done at Eisenhower to make sure that we're not missing anything. And if we didn't order something, that we're documenting why we didn't order that. So some of those things that we've implemented to make sure that we keep our metrics where they should be. Number one, just specifying the type of MI, making sure that's correct, number one. That our orders, we have order sets that prompt those key performance measures. So that way we don't miss anybody, and everybody who comes in and they've had a heart attack hopefully gets that cardiac rehab referral and all the appropriate medications. They're prompted to make sure that they order those. And then if they don't, there's a BPA, it's a little alarm that pops up on the computer screen to say, hey, a beta blocker wasn't ordered, is there a reason? So then they can put the reason why it wasn't ordered, whether it was their blood pressure was low or whatever that might be. And then we have very active participation by our physicians and our staff in our hospital, in our chest pain and our STEMI committees. So we talk about these guidelines, we go over patients, we do case reviews monthly and quarterly. And our providers are also very active in wanting to improve these metrics and making sure that nobody's slipping through the cracks. So this is our metrics, the breakdown when we first started. You can kind of see that we've trended up. And most of the reason why we weren't where we wanted to be in the beginning was documentation. So we've cleaned that up a bit, and you can see we're trending up and we're right where we want to be. And I anticipate we'll be able to keep these metrics where they need to be in 2025, so that in 2026, hopefully we'll be awarded a platinum award. That's my goal. And this is just to remind you what those awards, what the metrics, what we have to have. I have no doubt that we're going to get a platinum award in 2026. And at this time, we'll all take questions. I made mine short and sweet. I was last, and so I know everybody has been here, and we appreciate you staying. We'll take questions for this panel here, and then afterwards we'll have our drawing. So please stay, okay?
Goes through open heart surgery, or you might get the TAVR, probably the cardiologist, the TAVR, but or a chest pain guy, or STEMI, non-STEMI, and now he's in the hospital. He does not have a cardiologist, but he's leaving the hospital. Is there an automatic or a system within the hospital that says we're going to go help him get a cardiologist? Is that part of the?
I can speak to that. This is something I run into all the time, because a lot of times people come in having a heart attack and they end up having open heart surgery. They're typically seen in consultation by a cardiologist when they get to the hospital. These folks that don't have a cardiologist, it's their first heart incident. If the insurance isn't prohibitive, the cardiologist that sees them for the consultation in the hospital will typically follow them outside the hospital, at least for one visit. And then they will try to get them with another provider if they're not able to see them. So our interventionalists in particular don't always see people medically long-term, but they will see them for a visit, for a post-operative visit. Where we run into some stickiness is with some of the HMO insurances that don't, we don't have a provider here that at the hospital. So sometimes the cardiologist that sees them in the hospital does not necessarily isn't contracted in an outpatient setting. In those circumstances, what we would do is I try to utilize case management while they're here, because God bless the case managers, they make a lot of phone calls that I don't want to have to make, and I don't want to burden my office staff with. So I'll try to get the ball rolling while they're in the hospital, just find out a list of who they can see. I kind of have an idea now who's contracted with who. And if that doesn't work out, Bill, then we usually get the ball rolling once they get to us in the clinic. But there is a gap there. So ideally you would enlist the case manager while still hospitalized to try to to bridge that gap, because the last thing we want is to send somebody home with no follow-up after something like this. And there are things that should happen after a heart attack or after open heart surgery, that people should have follow-up, not just heart failure clinic. That's just a small percentage, but everybody should have cardiac rehab. Everybody. That's a game changer for most people. So I think that that's a great question and not an easy one to answer, but we have a really great group here. And there, you know, if you have a family member in the hospital and they don't have a cardiologist, I think the case manager is your best friend.
Are you saying like for heart attack patients? Yeah, I can say that for the heart attack patients, it is more prevalent in males. But you know, heart disease is the #1 killer of male and female. So it doesn't mean that we're not impacted. We're just impacted differently sometimes. And especially with heart attacks, it's important to recognize that females sometimes can have other symptoms on top of those classic symptoms. And so many times we see where females will ignore those symptoms and just think that they're having the flu, they have the flu or something different, because men will have this classic chest pain, shortness of breath, jaw pain, where women sometimes can also have upper abdomen pain, feeling faint, and so it can veer them in a different direction. But you know, we do see probably more men, but I don't know my percentages, you know,
I think
down to a T.
women have less heart disease when they're premenopausal, and postmenopausal, it pretty much evens out.
Yeah.
So that's kind of a standard across the board. We now know that estrogen is protective against heart disease. And so hormone therapy is, I don't know if that's going to change, because now we're seeing a lot more people using hormone therapy. It sort of went out of vogue, but now we're seeing a lot more people on hormone therapy. So, but there's a lot of disease processes that women have that are more prevalent in women, like mitral valve disease is more prevalent in women. So, you know, it's hard to make a generalization.
Yeah, I was gonna say structural heart, probably about the same, maybe slightly more with men, but I would say overall we see both sides.
And the diabetes component, so what Lydia was talking about symptoms. So diabetic patients often do not have typical symptoms, especially women. You know, they'll have indigestion, they'll just be tired, and ignore their symptoms, and they'll have no symptoms.
All right. If there are not any other questions, then we will go on to our raffle. Please stay. You have to be present to win. But we want to thank everyone who is on the Zoom for joining us today. This was a lovely symposium. I'm glad that we were able to offer it via Zoom for all of you out there. And thank you to everyone here that came in person to this lovely auditorium and to our Eisenhower campus.